Okay, good morning everybody, and again welcome to the Tech RRT post-deployment webinar. Today we're going to be looking at the infant and young child feeding deployment to Jordan that we had back in October 2019. And I am going to just run over very quickly the points of today's webinar. So I will give a quick overview of the introduction, so who we've got, with the presenters we have today, and the objectives of the webinar, and a very brief presentation on the Tech RRT. Some of you will be very familiar with the work that we do, so you can switch off at that moment. Others of you will not. And then we're going to hear about the context to the deployment. And for that, we're going to have Ruba from IMC, who we will hear from in a moment. And following that, the details of the deployment itself. So the terms of reference, the achievements from the deployment, the challenges that were met, any recommendations, and for the ongoing activities since the deployment back in August. And that will be followed by a question and answer discussion session. So on that note, if you have any questions at any point during the webinar, please feel free to put your questions into the chat box of Zoom. And when the question and answer session comes around, we will respond to those. And if, depending on the question, I may ask you to repeat the question verbally yourself at that moment. So I encourage you at any moment during the presentation to put your questions in the chat box. That would be great. And finally, I have already at the top of the chat posted the link to the webinar evaluation. If you were able to do this immediately following the webinar, that would be hugely appreciated. This is really important information for us to make sure that the webinars that we're producing, that we're delivering, are appropriate and useful for those that join. So that would be much appreciated if you could fill that in. It will take you a maximum of 10 minutes. Okay, is there anything else before we move on to the introductions? No, I think that's everything. Okay, so as I said, my name is Ben Allen and I am the Deputy Program Director of the Tech RRT. And today we also are very lucky to have Ruba Abu Taleb, and I will ask Ruba, are you there, to introduce yourself? I've unmuted you.
Yeah, I'm Ruba Abu Taleb, Nutrition Project Manager for the International Medical Corps Jordan office.
Great, thank you very much, Ruba. And Ruba was the in-country supervisor for this deployment, so is going to give us the introduction and background to the deployment itself. And we also have Brooke Bauer, who is the Tech RRT IYCF-E Adviser, who was the one who delivered the deployment. Hello, Brooke.
Hi, everybody. As Ben said, I'm the Tech RRT IYCF-E Adviser, and it was so I'm looking forward to talking to all of you guys about it.
Great, lovely to have you both here, and great to see so many people on the line. So, without further ado, let's move on. So the objectives of these webinars, the post-deployment webinars, and therefore the webinar today. Firstly, it's to foster discussion on the, in this case, IYCF situation in the country. We hope that this, as I said before, we hope that the webinar and what's presented will initiate some questions from you. So please do, as I said, put those in the chat box, and we can discuss IYCF and the context in Jordan when the time comes. And hopefully that discussion will continue in country following the webinar. Secondly, very simply, a simple objective is to share information on the Tech RRT IYCF deployment to Jordan. Obviously, we hope that the activities from the deployment and the goings on in terms of IYCF in Jordan will be of interest to people outside of Jordan. I can see we have lots of people from Jordan itself, but also a few from other countries in the world. So I hope that what you learned today will be able to have some application to other contexts. And thirdly, we hope that these webinars facilitate those in the country to improve the follow-up of the work done during the deployment. And on that note, we are going to hear from Ruba and how work done since Brooke left at the beginning of October, what work has been done since. So we will hear from her soon. And I didn't mention any timings. So just roughly speaking, we're going to hear from me for another 5 minutes, up to maximum 10 minutes about the Tech RRT. We will have 10 minutes or so from Ruba on the context and the background to the deployment, and then roughly 20 minutes from Brooke on the content of the deployment. And then at the end of Brooke's presentation, Ruba is going to give us that perspective on what's happened since. Okay, so what is the Tech RRT? Very briefly, the Tech RRT is a rapid response mechanism that supports improved nutrition programming through deploying advisors, remote support, and capacity strengthening initiatives. So we both, yes, provide direct support in the way of advisors, one of our 4 advisors, and also provide remote support with those advisors. And capacity strengthening initiatives, these are largely through capacity strengthening webinars. Some of you may have been able to join our webinars, IYCF-E integration, one series, and then also the non-breastfed infant series. And those are all available on our website, the recordings and the resources, if you were not able to attend those. And we're a consortium of 3 NGOs, International Medical Corps, Action Against Hunger, and Save the Children. In fact, 4 NGOs, because we have Action Against Hunger Canada and Action Against Hunger USA, all of whom have particular specific roles, technically focused roles in the Tech RRT consortium. And we're very fortunate to have the support from 4 donors, USAID, Irish Aid, CEDA, and Save the Children, who also support IYCF-E deployments. And we work very closely with the Global Nutrition Cluster and UNICEF. All of our deployments are reviewed by our deployment steering committee, which consists of the consortium members and the GNC and UNICEF. And finally, we are working as part of the newly established Global Technical Assistance Mechanism for Nutrition. And the goal of the Tech RRT is to improve and strengthen the technical quality of programs and assessments for improved nutrition outcomes of affected populations in emergencies and protracted crisis situations. So I touched on what the Tech RRT team consists of. So firstly, we have a program management team, which is myself, the Deputy Program Director, and Andy Kendall, the Program Director. And we coordinate the deployments and the work of the Tech RRT delivered by our 4 technical experts, technical advisors. So we have, and they have 4 different focus areas. We have one, Alexa Humphreys, who is hosted by Action Against Hunger Canada, and she is the assessment advisor. And secondly, we have Martha Nakakandi, who is hosted by International Medical Corps, and she is the community-based management of acute malnutrition and IYCF-E advisor, covering both roles. And thirdly, we have Brooke, who's on the line with us today, who is hosted by Save the Children, and she is our IYCF-E advisor. And fourthly, we have Sona Sharma, who I'm very happy to see is on the call today, because she has not actually started with us yet and will be starting in her role on the 3rd of February. So as you're here, Sona, welcome. And finally, if, and it is often the case, we have too many demands for the capacity of our 4 advisors, we also recruit. We have standby consultants who we're able to recruit to fulfill those additional needs. For example, we have had 2 deployments to Angola recently, a CMAM and an assessment. And our CMAM, Martha and Alexa, were not available, so we had consultants to deliver those. And as I mentioned earlier, we have a deployment steering committee that reviews and endorses and deployment requests and input into the TORs. Those are the steering committee members and UNICEF and the GNC. So a quick overview of what we've done. So the Tech RRT has been in existence since 2015, and we've done a total of 58 deployments to 21 different countries. And this is well up to date. We currently have 2 ongoing deployments in Zambia, an assessment and a CMAM deployment. And we have upcoming deployments, both IYCF-E to the DRC and Venezuela. And finally, who can request? How does one request support? So who can request? Any agency, national or international, or other stakeholder with nutrition technical need. So that could be nutrition cluster or sector group, governments, donors, international NGOs, and national NGOs. And we particularly encourage national organizations who we feel have more limited access to the kind of technical support that we provide. And we strongly encourage national organizations to seek our support. And finally, how? It's very easy to do. You get in touch with myself or Andy, and we take it from there. The process is you get in touch with us, we have a call to discuss what your needs are and discuss whether that fits with our remit and how we can shape a potential technical assistance deployment. And then the next step is to develop a terms of reference, find appropriate HR and funding as well. And just a final note on funding, we have various funding modalities from complete cost recovery, i.e. the requester covers all the costs, to no contribution, where we contribute through Tech RRT grants, and any arrangement in between. We often have cost sharing arrangements where the requester will make some contribution and the Tech RRT will make others. Our main priority is that the technical assistance need is met and that finances are not prohibitive. Okay then, enough from me about the Tech RRT. We will now hand over to Ruba, who will give us an overview of the context in Jordan and the background to the deployment. Over to you, Ruba.
Good day to you, everyone. As I have introduced myself earlier, this is Ruba from International Medical Corps Jordan office. Can we move, Ben? Okay. First, to begin with, the total population figure of Syrians, persons of concern currently residing in Jordan has reached 654,192 persons of concern. As you can see below here, that the majority of those refugees, they reside in urban settings, more than 80% in urban settings and less than 20% in camps. Now, according to latest WFP assessment, the main source of income for refugees in camps was the WFP food voucher. And for refugees in host communities, it was the unskilled labor in host communities. Now, actually, these data and the figures below were extracted from WFP assessment that was performed in 2018. As a result of that assessment, they found out that a lot of Syrians, they sell their food vouchers to procure other goods. So it was decided that they have to change the type of assistance, and they gradually started to shift the food voucher into credit card that can only be redeemed at at certain premises or certain markets within the camps. But personally, I do not think that food security status would be improved by this approach very much, because now the main source of income has become the cash for work for Syrians in camps, and it's coordinated according to very strict guidelines. One person can work per household. The rotation for work is only 3 months, and afterwards this person has to remain unemployed for 3 consecutive months, and so on and so forth. Still, we don't have data on current status of food security, but I do not expect that it has been improved. We can move now. Ben? Okay. This map shows the main locations where the Tech RRT trainings took place. Thanks to Brooke, actually, she was quite cooperative, and she agreed that we can do different cycles of training apart from the main training in Amman. Now, we had 2 trainings in Zatari camp, one training in Azraq camp, and several trainings in Irbid. All of those trainings consisted of, contained, or let's say had trainees from different NGOs. Now, the main purpose for these different trainings was that we need to reach out to each and everyone, frontliners who, let's say, are in contact with mothers and children. Those include nurses, GPs, pediatricians, midwives, gynecologists. We circulated the invitation to everyone, and we had a lot of attendees to those trainings. But the main training in Amman included members from different NGOs from different locations of Jordan, North Jordan to South Jordan. And it was a 5-day training. The first 2 days were for general health practitioners, and the 3 remaining days were particularly for nutritionists. It was only for, it was a training of trainers on IYCF-E, and there was a session on CMAM. We can move now. Ben. Yeah. Now, this figure gives a glimpse on the status of infant and young child feeding in both camp and urban settings. This figure was extracted from 2016 Interagency Nutrition Survey. Now, you need to know before we start to go through this slide that usually, or in Jordan, you can always see that the IYCF figures and the IYCF practices in urban settings are much lower or inferior than practices in the camps. This is due to different reasons, because it's impossible to reach out to each and every woman who deliver in urban settings, in rural locations. But in camps, somehow this is impossible. This is possible in camps. I'm sorry. This is possible in camps. And also for women outside the camp, the transportation cost is an issue. The health-seeking behavior for women is really, let's say, critical for Syrian women. They have a lot of dependence, and they are unable to move freely outside the camp. First to begin with, the early initiation of breastfeeding, as you can see, the first group of columns. In both camps, more than 50% of newborns were breastfed within the first hour, but in host communities, the figure is around 37.1%. Also, for the exclusive breastfeeding in both camps, it's much better than urban settings. In Zatri camp, it's 53.7%, and it's 38.2% in Azraq camp, and only 19.1% in host communities. I really need to highlight that UNHCR in its cooperation with outside hospitals, with hospitals outside the camp, to refer mothers to deliver. Part of their agreement is not to fund any activity that involves formula or breast milk substituent feeding. This is somehow has controlled the number of women who get back into the camp with having their children fed by bottle for the first time. For the remaining numbers, I think you can go through them, and you can always see that the IYCF practices in camps are much better than in host communities. We can move now. Now, this slide give you these slides give you a brief glimpse about the kind of programming since 2012, onset of emergency, till mid-2017. Zaatari camp was the first camp for refugees, and it was officially opened in July 2012, and that's when nutrition programming started. In urban settings, we only had facility-based CMAM, OTP and SFP activities under UNHCR partners, and they were mainly clinics located in north parts of Jordan. And there was a community-based IYCF under Save the Children Jordan in Amman and South Jordan. Now, this leaves the community in North Jordan really lacking actual IYCF activities. Back then, the agency depended on referral pathways with other NGOs. The Nutrition Working Group took the responsibility to train different NGOs on NUAC screening and refer malnourished children to receive needed assistance. In camps, the mode of programming was different. It was facility-based OTP SFP plus breast milk substituents prescription under UNHCR partner. And there was the community IYCF and SFP under Save the Children Jordan. Back then also, Save the Children had a caravan for IYCF activities at the border transit area. It was called Ruba al-Sarhan. Now, the camps were really controlled in terms of CMAM and IYCF. A lot of children were able to continue with nutrition programs and not falling away, not dropping out of the programs or defaulting from the program. Now, we need to highlight that all SOPs and guidelines developed by the Nutrition Working Group were endorsed by Ministry of Health, as there is a member representative regularly attending the Nutrition Working Group. We can move now. Okay. Now, in 2017, mid-2017, after 5 years of the emergency, it was decided that the apart from funding shortfalls, also that the mode of service has to be changed, because now it has become not an emergency anymore, and now we need to maintain the resilience of the camp communities and the host communities as well. The type of programming now in urban settings, it's under UNHCR partner. It's a facility-based CMAM IYCF, including PMS prescription within primary healthcare center of, as I mentioned, UNHCR partner. But still, we don't have community outreach activities, not North or South Jordan. The community now for IYCF, it's a gap. Now, for both camps, Azraq and Zaatari, it's the responsibility of International Medical Corps. And I can summarize the activities that we do is that now we have 4 clinics in each camp, and coordination with all health actors is ongoing, so that once a mother is identified as pregnant, she is referred by the RH clinic into the nutrition clinic to receive counseling on maternal nutrition, plus early initiation of breastfeeding. every mother who delivers, all RH partners, gynecologists in the camp are educated and trained how to support a woman to breastfeed within the first hour of delivery. Nevertheless, our staff, either national nutrition counselors or community nutrition volunteers, Syrian, they reach out to mothers within the first 24 hours after delivery to assess how breastfeeding is going on and refer the mother back to IYCF clinic to receive needed counseling. Here we need to know that also there are a lot of mothers with delivery complications referred outside the camp. Sometimes they're getting back into the camp might take a few days. We cooperate with the referral department so that we can get a list of those names and reach out to them as early as possible so that we can put our hands on breastfeeding and try to sustain it as much as we can. As I listed here also, MOAC screening is there at triage point. We can move now. Now, since transition, when I say transition here, I just refer to the concept of integrating nutrition into primary healthcare. Before June 2017, nutrition, IYCF, SFP used to be part of community-based activities implemented by Save the Children, actually. But after the integration, we have nutrition clinic, which is part of the primary healthcare center. And there should be a cooperation and a bit of awareness on what the nutrition clinic does so that the referral pathways between different actors within the same health facility and other health facilities would remain ongoing. As I mentioned, that since transition, the staff operating CMAM IYCF, mainly staff in Zaatri camp, and urban staff, the new UNHCR partners, have never received any kind of IYCF harmonized training package. And still, the IYCF activities are really limited and are really down to breast milk substitutes, substituents prescriptions and group education sessions. Also, there was, let's say, an assessment in 2016 before the neonatal resuscitation training, and it was followed up by another assessment in 2018. The two assessments revealed that there's a need to focus on developing the capacity of healthcare providers. Not only nutrition counselors need support, but also all members working directly with women, either in the reproductive health context or in the pediatric context. We can move. Now, I mentioned earlier that the emergency is not an emergency anymore. It has become a protracted issue, and we have to maintain the resilience of people living in the camp and people living in host communities. Now, usually in such contexts, development partners step in and support different programs, but unfortunately, IYCF was not included in any of the development programs. Plus, the baby-friendly hospital initiative is not very well recognized in urban hospitals. Now, this is critical not only because mothers who are referred back to the camp, sometimes their infants are breastfed at least once by a bottle, but also because our staff currently working in camps or in urban settings came from those facilities. So they are somehow mirroring the practice that they used to do in those private hospitals before they got a job with an NGO. So still the concept, a baby-friendly hospital, is not really common 100%. It is gradually being generalized by UNICEF and UNICEF partners, but there are a lot of hospitals in Jordan and a lot of private sector hospitals, and this needs a lot of work. Involved practitioners in reproductive health and pediatric medicine, even after the integration, they only refer mothers who they suspect a need for IYCF support to IYCF clinic. They never provide the counseling themselves. And also this is critical because sometimes Syrian mothers like to hear the information coming out from a doctor. It really has a different impact when she hears the same piece of information coming from a doctor than hearing the information coming from a community nutrition volunteer or from a nutrition counselor. Finally, the staff are not trained on how to compensate for the lack of outreach counselors. Here, I just also want to mention something that Brooke did. She met with the team different times in different camps, and she advised how nutrition counselors should prioritize the needs of different mothers, and how urgent each case has to be followed up, and how soon a child can be, let's say, shifted to breast milk substituent before we try everything with the child. I think this is it.
Great.
For this part. Yeah.
Okay, thank you very much, Ruba, for highlighting the context in Jordan, the nutrition situation, the nutrition program currently in place, and finally for highlighting those 5 points justifying why IMC came to the Tech RRT to request and develop a deployment for technical support. So before I hand over to Brooke, I just want to highlight again, if I may, that please do add any questions you have at any point into the group chat. Don't be shy, and we will address those. And if you are shy, feel free to do it privately to me, or you can do that on the chat box, and we will address those during the discussion session. Okay, thank you. All right then, Brooke, over to you.
Thanks, Ben. And thanks, Ruba. That was a really good overview. I think it's really helpful to get that background context. As you can see, the Jordan program did really well in controlling the BMS distribution in the camps, and you can see that through the rates and statistics that she shared earlier. One really good source, if any of the participants want to look into the history of how they did that in the very beginning, when it was an emergency. There's a field exchange on the Emergency Nutrition Network written by Surah Al-Saman, that's her photo there. She assisted with counseling TOT. She wrote a field exchange in 2015 that kind of gave a background. She was with Save the Children at the time. And so it might be interesting, and then maybe we can link that for the participants for later if they want to follow up on it.
Yeah, definitely, we can provide any resources that are mentioned, and also the training slides as well as the recording following the webinar.
Great, thanks. Okay, so we can go to the next slide. So the deployment dates were from the 31st of August to the 4th of October, 2019. As Ruba mentioned, it was to strengthen the delivery of IYCF amongst nutrition and reproductive health actors, implementing camp and or urban-based nutrition and reproductive health activities. So as the programs moved into the protected, as a crisis changed from emergency to protected, as things settled down, the integration of IYCF among reproductive health programs became more and more important. And we mainly worked with reproductive health and CMAM partners, operating in Azraq and Zatri camp, and as well as urban actors in Urbid. Next slide. So the objectives were to strengthen the integration of IYCF into RH and CMAM programs, to strengthen IYCF counseling skills amongst midwives and health and nutrition actors, and to build local capacity to deliver training, which we did while we were there through different methods that we'll go over now. Next slide. So some of the activities that Ruba had mentioned, there was quite a lot of on-site mentoring and discussion. That was partly to understand what the context was, to make sure that we were creating trainings and orientations and sensitization sessions that were completely contextualized. We did a lot of, I did walk through with Ruba and some of the nutrition workers in the camps to go through how in-home BMS prescription follow-ups happened, what was happening currently, and how we could shift that as we created the joint action plan that was created after the deployment. The second photograph that you see is a midwife in Zatri camp. She's actually, from what I understood, the first, and Ruba can correct me, the first licensed midwife in Jordan. And she attended one of the orientation sessions, and she has these are examples of some of her family planning tools and her IYCF educational tools that she uses. It was quite interesting. The one in the center, the breast, is made out of one of her stockings and some cotton and some cardboard. So a really good example of how you can make training tools out of just everyday materials that you might have. The third photograph is an IMC nutrition counselor walking through Zatri camp for a BMS follow-up visit. And so these are examples of some of the mentoring and discussions that we had in the field itself. Next slide, please. There was also, as Ruba mentioned, integration orientations for medical providers. That was done in in an urban setting. It was done in Zatri camp, and it was done in Asra camp as well. And there was multiple organizations that attended those, both reproductive health and nutrition actors. And the third photograph is a IYCF-E counseling training of trainers, a TOT. It was a 5-day session. This is a photo. In the photograph, they're practicing. They're using tools, practicing hand expression with a mother. Next slide. So some of the achievements that were. Some of the things that were achieved. A comprehensive IYCF, CMAM, and RH integration action plan was developed with the nutrition working group partners. This was done near the end of after the deployment, near the end of the deployment, using all of the things that, all of the information that was gathered during the deployment, including the information and gaps that were recognized in the orientation sessions, as well as and the trainings in the TOT. So it outlines gaps, it provided recommended activities, the nutrition working group partners created the timeline for it, and identified required resources needed to complete what was in the plan. And you'll see in a few slides, you'll see that they've really moved along in implementing some of the activities. The second achievement was IYCF integration monitoring tools. They were reviewed and revised. They were written within the suggestions were written within the joint action plan for the partners to consider. Contextualized IYCF orientation package for RH actors was developed. So we worked to develop a 1-day, but it could easily be split into 2 days. An orientation package that the identified trainers or nutrition working group can adapt to provide an orientation of IYCF to reproductive health actors, so that we can continue to cascade that information into the facilities. We completed 3 1-day IYCF orientations. They were delivered in both camp and urban settings for RH actors. Initially within the TOR of the deployment, it was 1 2-day orientation. But as Ruba mentioned earlier, we wanted to be flexible with that to make sure that we were able to have the furthest reach possible. So it was adapted to 3 one-day sessions, as many of the partners weren't able to do 2 days. There were other ongoing activities that were large-scale activities that were happening concurrently within the camps. And so we adapted it to make sure that we had the largest outreach. And we had 32 participants in total over all 3 of the sessions. Next slide, please. Next slide, please. Thanks. Thank you. We had a contextualized 5-day IYCF counseling training TOT package was developed. Within this 5 days, we had 22 participants completing the entire training. However, some days participants came in just for one session or 1 day as they wanted or as they were able to. We kind of had that open door. The nutrition working group agreed that an open door policy to allow for get that sensitization for certain topics that we were discussing. But 22 participants completed the entire training. Trainers were identified based on the participation within the training, and based on the assessments that were completed at the end. And so 4 master trainers were identified. There were 7 trainers identified, and 8 support trainers identified who would be able to build up their skills. And actually, looking at the participant list here right now, there are quite a few of these participants listening to this at the moment, which is great to see. And there, we also did an IYCF orientation report was produced and delivered to the nutrition working group and the partners. Okay, next slide. While it was a great deployment and it was very positive in the response, there were, as always, some challenges. The TOT and orientation sessions were met with a very positive response. However, there are limited monitoring practices in place to ensure that the skills are put to use. So that is something that was included in the joint action plan, and the nutrition working group, and they are engaged in this. They have to continue to mentor, do on-the-job site mentoring with the participants, making sure that the skills are kept up to date, and making sure that the tools that have been developed are being used appropriately within the sessions that are then cascaded down. Challenge 2, training and capacity building, was much needed, but it was also coordination and monitoring the programs is also required. So this could be led, the recommendation was that this could be led by IMC and or the nutrition working group as a collective. Nutrition partners to seek technical support if necessary to reestablish solid leadership in order to improve coordination among the programs and monitoring of the programs. While, for example, the BMS prescriptions are very controlled, and as I said, it is one of the better programs that I've seen for BMS control. It still has improvements that need to be made, specifically with the prescriptions being a bit more in line with the SOPs that have been developed. There are some flexibilities in that, but I know that the nutrition working group is aware of that and working on that. So I have confidence that they are moving forward with that. Next slide, please. As always, a challenge. Communication can be a bit inconsistent after a deployment. The joint action plan really was designed to be the nutrition working group's plan, but there wasn't much engagement on the activities and so on. So the recommendation would be that the continued push from the Nutrition Working Group and IMC, who requested the deployment, to move plans forward in country and to make sure that the Joint Action Plan is implemented. And as you'll see from Ruba in a minute, they are, as I said, they are moving forward. Go ahead, next slide. So some lessons learned. Some technical support on IYCF and multi-sectoral integration would be beneficial to IMC Jordan specifically, as IMC is the lead organization at the moment, providing the largest, they're the largest provider for the services in both urban and camp settings. And I know that I know that IMC is aware of this, this technical support need. So the deployment was perhaps slightly too short. After the training, monitoring and evaluation tools were needed to be put into place to measure the application of knowledge by the participants. So if it was slightly longer, we could have really developed and implemented these tools. However, as I said, they were outlined in the Joint Action Plan. The partners just need to have a clear path forward to implement them. Next slide, please. So I'll hand this over now to Ruba, as she's in country, so she'll be able to tell you what has been put into place and what will be going into place further in the future. Thank you.
Okay, hi again. After the main training in Amman, the 5-day training took place, the Nutrition Working Group, led by UNICEF, the chair for the Nutrition Working Group in Jordan, the Save the Children Jordan are the chair co-lead for the Nutrition Working Group, and the other involved agencies, including IMC as UNICEF partner, and Caritas Jordan as UNHCR partner for urban activities. We all met to go through the recommendations and action plans suggested by the Tech RRT Adviser. Actually, the first thing was the Joint Action Plan. Brooke defined several steps that have to take place gradually throughout 2020 and the years afterwards. A lot of steps were taken so far. First of all, the joint statement. In fact, it was developed in 2012, but it needed few updates, and now it has been updated and circulated within the Nutrition Working Group. The training materials developed during the deployment are being translated to cascade the training. And by training materials, I mean the presentations that were provided by the Tech RRT Adviser. And now in English, they were just circulated to all actors. But currently, the translation is ongoing for those presentations, so that we can cascade the training not only for nutrition counselors or advanced health actors, but also to community nutrition volunteers and primary healthcare practitioners who are in direct contact with Syrian mothers and children. We have now the poster of 10 Steps for Baby-Friendly Hospital Initiative was translated into Arabic by WHO, and now it's under print, so that we can have those posters on the walls of all health facilities in the camps. Next slide, please. Luckily, the modality of work for the IYCF program under UNICEF has been modified for 2020. In fact, it was suggested. Now, you need to know that UNICEF is the main funding partner, the main funding agency for the entire IYCF context since the beginning of the crisis. Their suggestion now is that to shift the mode of work into building the capacity of the main community by having part of the counselors currently working in the camp shifted as trainers, and they will be deployed to train other health actors within the same camp and support peer-to-peer support groups within the camp. Now, at the latter health coordination meetings, I took the chance to introduce the new hierarchy for the new working modality, and I mentioned that we will coordinate with WFP because we need to utilize their public kitchens in the camp to facilitate cooking demonstrations. The peer-to-peer group sessions or peer-to-peer support groups are supposed to include mothers, plus mothers and mothers-in-laws, and couples counseling. Also, we need to engage men and boys in our IYCF approach in 2020. All community nutrition volunteers in Zaatri and Azraq camp received one-day IYCF training utilizing a translated version of the material developed during the deployment. The bottle amnesty issue, it was done, I figured out that it was done in Azraq camp, but in Zaatri camp, it was not. As I mentioned earlier in this presentation, the staff in Zaatri before the deployment has never received a comprehensive IYCF training. The bottle amnesty is now being done in Zaatri and Azraq camp. And now that we have 2 trainers per camps, we are expecting more and more campaigns and general activities in the camp so that we can have like an event, get up, bring up your bottle and take a cup and a breastfeeding child, for example. We are still brainstorming, but we are expecting to have more and more IYCF activities in 2020. Yeah.
Great. Okay. Well, thank you very much to Brooke and to Ruba for those for presenting first the deployment and then the work that has been done since. Clearly, it struck me that there's a lot of work was done during the deployment, but also since the deployment in regards to improving the IYCF-E situation in Jordan. And particular credit should go to, of course, Ruba and Brooke, but also the Nutrition Working Group, with whom I know that Brooke and Ruba have been working very closely with in the development and implementation of the deployment activities, and since, amongst other things, with the development of the joint action plan. And one aspect that struck me particularly about the presentations was the fact of this being no longer an emergency context, but still with emergency actors present, and therefore the connection between the initial emergency response and the ongoing development context of in Jordan raises lots of questions and particularities. And in that regard, I want to come to one of the questions that we've had. I wonder, from Alexa, and I wonder, she says, what was the level of engagement from the Ministry of Health during the deployment? More specifically with IYCF, and how did they engage? And maybe I can expand her question a bit, not just during the deployment, but within IYCF more generally, because obviously for a more sustainable and future perspective, engagement of the Ministry of Health is very important. So Ruba, maybe would you be able to respond to that question from Alexa with my addition?
Yeah, I mean, at the beginning of the deployment, at the beginning of September, an invitation was sent to Ministry of Health so that they would attend the either attend the training or attend the kickoff meetings or the follow-up. In fact, we were in touch with them, but they were not physically present at the meetings. They provided their input and their recommendations, but I have integrated earlier that all SOPs and guidelines that are developed by the Nutrition Working Group in Jordan are endorsed by Ministry of Health. Now, the invitation to attend the Nutrition Working Group is regularly sent to them, and they regularly attend the Nutrition Working Group unless there's, let's say, a major issue, they are unable to make it. I hope that responds. Yeah.
Okay, great. Thank you. Maybe I can now thank you for the questions that have come in. We have a couple. I encourage everyone else to, those who've got those questions in their head that they not sure whether to ask or not, I suggest you do. So please put them in the chat box. And now I'm just, if you don't mind, I'm going to just ask Butena from UNICEF, who would like to give an update on the BHFI and IYCF situation in UNICEF. Sorry, in Jordan. She's from UNICEF. She had some things to add to the presentation. Butena, are you there? I'll unmute you.
Yes, I'm there.
Hello, Butena. Butena, yes. Go ahead.
Hi, hi everyone.
Just a few minutes, please, not more. Thank you.
Okay, not more. Okay, thank you. Hi everyone. I would like to thank the TRT team for at the beginning, and I would like to thank everyone who has supported us and made this deployment a success. Actually, I would like to thank Brooke, Ruba, and Sura, who did a great job, you know, to raise the awareness and also to train the service providers on the IYCF. I would like to add 2 points actually. Here in Jordan, as you mentioned now, Ben, the issue of that it's no more emergency. So it's we call it emergency, non-emergency. We are towards resilience. And so the work now is shifting now from the communities more to work on systems. And in this area, I would like to add that the role of Ministry of Health, it's not only to approve the documents related to IYCF, but again, to endorse it within their materials and curriculum that are being, you know, given to the nurses and midwives and doctors in the primary healthcare. And this is one of the main projects UNICEF is working on now, is to integrate IYCF within the primary healthcare. The other thing also, it's about the baby-friendly hospital initiative. Actually, through UNICEF, we revived this initiative last year. It was there before, but unfortunately, it was not that successful. So now the unique part that we are linking it to accreditation of the hospitals. We started with 5 hospitals last year, and now we are generalizing it to another hospital, either, you know, military hospitals, emergency hospitals inside the camps and outside the camp, the government and the private sector. The point here, you know, that it is linked directly to IYCF, where, you know, IYCF, because the majority of the deliveries almost is around 98% among refugees and Jordanians and other nationalities settled in Jordan are happening in hospitals. So this is the biggest opportunity, or the first opportunity, to enforce the implementation of IYCF practices, starting from early initiation and helping the mother to continue later on exclusive breastfeeding. This is what I wanted to highlight about the baby-friendly hospital initiative and the IYCF, and also we are using IYCF as an entry point to reduce neonatal mortality, where Jordan as a country will be reporting on neonatal mortality and how to reduce the neonatal mortality. Again, you know, I would like to thank everyone from our partners, other agencies in Jordan, and even from neighboring countries, because we are working also with the people who are responding to the Syrian emergency in Syria, Lebanon, and Egypt, and Iraq even. You know, we have some people coming from Iraq. So just to extend my thanks and appreciation to everybody who supported us in making this a success. And special thanks to Save the Children International and Save the Children Jordan, who are our partners, and we started actually working with them in 2012 to shape the IYCF according to the context of Jordan. As you know, that IYCF, it was not implemented before in high middle income countries, and we tailored even the modules, and we call it in Jordan IYCF Plus, because we added many areas other than IYCF, like, you know, the management of diarrhea, management of other, you know, infectious diseases that might, you know, be affecting breastfeeding. We included it within the IYCF modules. And we are ready as UNICEF with our partner Save the Children and IMC to extend our experience to other countries in the region and other regions. Thank you.
Great. Thank you very much, Butena. Yes, thanks particularly for highlighting the particularities of this post-emergency middle-income context. So yeah, thanks for that contribution. Ruba or Brooke, do you have anything to add in relation to what Butena said, or can we move on to some of the other questions that we've got in?
From my side, we can move on. I appreciate that you stepped forward and included that perspective into the discussion. So that was really nice. Thank you.
Thank you.
Okay, great. All right then. Well, I'm going to go to a question from Andy Kendall. She is the program director of the Tech RRT. She says, what's the type of WFP assistance in the host communities, bearing in mind that here the deployment and the activities were working in the two camps and also in one urban area. So she asked, what is the type of WFP assistance in host communities, and how, if at all, does this work integrate with the IYCF-E work that we've been discussing today?
In fact, WFP food assistance in urban settings, it is limited to WFP food vouchers. But unfortunately, the food vouchers were downsized in 2014. There was upgrading in 2016, but still it's not enough. As Butena mentioned, Jordan is an upper middle income country. Food is really expensive in Jordan. And what is being provided to refugees is either 10 JDs, Jordanian dinners. This is around $14 per person per month, according to the UNHCR registration or asylum seeker. So if a family consists of 5 persons, they receive 50 Jordanian dinners per month. And this is only for food. And honestly, for someone who lives in Jordan, 50 Jordanian dinners are not enough for 1 week. So this has really affected food security massively in urban settings. But also, there's another issue that people in urban settings, they have to worry about rent and health services. If you analyze the food security status, you will find it very much linked to the type of health services accessibility by refugees. Before 2014, Syrian refugees with valid asylum seeker, they were able to benefit from public health services for free. But after 2014, they started to pay at the non-insured Jordanian rate. And afterwards, in 2018, the regulation was changed, and they have to pay even more. So they are forced to look for cheaper alternatives, and just to secure the rent, so that they wouldn't end up in streets. So either they would sell their food vouchers, or they would procure non-fresh foods, those foods that can reside for longer period of time. They wouldn't seek health assistance. They wouldn't they would spare the transportation costs. They would never reach out to urban nutrition clinics where IYCF services are there. This is how I can think it affects the IYCF implementation.
Thanks, Ruba. And I wonder if there has been any discussion over using distribution points for WFP as contact points for IYCF intervention.
I'm not sure if we have now in early context of emergency, we had WFP distribution points, and maybe at in the camps and reception area, that area does have WFP activity, and also it has an IYCF activity by nutrition counselors, because once we are alerted that there are persons in the reception area, a nutrition counselor goes there and provide the needed IYCF assessment and support if any infant or any mother is in need for support. But in urban settings, as far as I know, I'm not aware of WFP distribution points.
Okay, great, thank you. All right then. Well, I'm going to move on to another question that we have from Colleen from World Vision. Hello, Colleen. Can you share, Ruba, a little more information on how the peer support mechanism works?
Yes. Now, in the camp, we do have locations as community centers, and those community centers are attended by different population groups. We utilize those centers to ask mothers, where would you like to have some discussions on breastfeedings, regular discussions, like on weekly basis. All mothers agreed that they would like to host this kind of activity within their household, within their caravans. Now, there's something, I don't know, distinctive about Syrian population in camps. They are really they like to socialize. And they like to visit each other they like to visit each other's caravan. So what is being implemented now is that we start with the, I don't know how to translate that in English, but each street in the camp, there is an identified head or person identified socially by her neighbors and her relatives within the same street, and she's like the reference for them. So we start with her and we ask her to compile number of women who breastfed, and number of women who are currently pregnant. But like the number we are looking for is not more than 5 within the session. And we continue the plan for 2020 now, because this is the time where we officially start to implement the peer-to-peer support groups. We started something in 2019, but we were just trying to see how is it going. But officially now we will start implementing it. And the plan is to have 24 support groups on annual basis, so that in each month, in each camp, we would have 2 support groups. With each one of them, we will meet 4 times. So the meeting will be weekly with each support group. Now, the next step is supposed to be having identified persons from within the group, or having the entire attendees of the group starting other groups. This is how we are looking forward to continue. But still, we are looking into making this a success. regularly doing those meetings at mothers' caravans or at the street head caravans. And this is how the peer-to-peer support groups are going.
And can I add a little bit to what Ruba just spoke about? Yeah. So when the peer support groups, just for the participants, the peer support groups discussion was a large part of the discussions that we were having in country while the Tech RRT was there. And it was a large part of the last day, specifically the last day of the counseling TOT. One of the reasons why it did come up, the peer support groups, is one, it wasn't being implemented. It was previously implemented, I do believe, Ruba, you can correct me, but hasn't been implemented for some time. And one of the comments that I received when talking to one of the nutrition workers in country when I first arrived was, what she said was, we just want them to want to breastfeed. We just need to make them, or we need to help them want to breastfeed. And I said that, and the discussion went to, changing the culture of breastfeeding within the camps and doing that through peer support groups. And so I see this personally as part of the joint action plan, one of the most important parts that is being implemented. And so it's great to hear how they're doing it and how they're moving it forward, as it's really important. And the other one that was in the joint action plan that Ruba mentioned earlier that's being implemented that I see as also very important is the bottle amnesty programs. As the BMS is controlled within the camps and the nutrition workers do work with the shops or help monitor the shops on BMS distribution and sales, that doesn't necessarily turn over to bottles as well. And so there was less control. And so it's great to see both of these things, these really important activities being implemented. And so the nutrition working group has done a great job, I think, in that respect.
Great. Thanks very much, Brooke and Ruba. I have a question, but before I do that, I've had another question submitted to me. So I'd like to pose that one, and then I think that is all of them for the moment. The question relates to breast milk substitute prescription procedures and what makes them work so effectively in Jordan.
Okay, at the beginning of the crisis, you can say that as I mentioned, the IYCF was a community-based program in Zaatari camp. At the beginning of the crisis, we only had one camp, Zaatari camp. It was closed back then, and refugees had no other resource to procure milk formula. And the only source to have the milk formula was the milk formula prescription clinic. So if they don't breastfeed or if they are unable to breastfeed, they were examined by a midwife. And once the system was, let's say, in place, and the camp started to grow, and we started to have markets in the camp, people were then convinced that they are able to breastfeed because there were a lot of efforts implemented to make the mothers want to breastfeed. Now, once the markets started to smuggle milk formula, we regularly used to report this to the health coordinator in Zaatari camp, and that person used to take over the responsibility of extracting those formulas from the market and identifying suppliers. For Azraq camp is until now a closed camp, and refugees are unable to go out and procure milk formula, and that's why their only resort to have milk formula is the milk formula prescription clinic. Now, the only challenge that we are having is that a lot of refugees now urbanize, they leave the camp. A lot of refugees go for delivery outside the camp, but then they decide to stay in postpartum with relatives outside the camp. So sometimes we have these gaps in service because refugees were not there in the camp. One of the points for which, according to which we give breast milk substitutes is the mother has stopped feeding and relactation failed. So a lot of mothers leave the camp for a very long period and then get back to the camp with no breast milk. We try and work hard to induce relactation, but we're not always lucky. But I think I have given the reasons why, because the mode of work and the nature of the camp, it was really a closed camp, and nutrition counselors under UNICEF Save the Children were everywhere, and they were coordinating campaigns for bottle amnesty and to support breastfeeding everywhere. But after 5 years, the integration of IYCF into primary health care, once this has started under UNICEF IMC, the idea was there with the population. Everyone knows that you cannot get a milk formula 10 that easy. You have to approach and seek the assistance of nutrition counselors. I think I have responded to that.
Thank you, Ruba. As we don't have any other questions, maybe I can ask one. During the deployment, you put together, with the support of Brooke, the nutrition working group, put together a joint action plan, which has a number of different activities on it. And I wonder what are currently the biggest challenges that you're facing or you will face in implementing that joint action plan successfully, and what are your ideas for mitigating or overcoming those challenges?
Now, in fact, while we were going through the action plan, we were identifying by name who is going to do this task and that. So, so far, I do not expect that we are going to have a challenge, but we might have some delays because the action plan requested that we need to present something to the health coordination working group, and we need to revisit the IYCF within different working groups. So I think this might take some time according to the schedules of nutrition working group members and who's going to take this responsibility, because I don't think that one partner will take it over. But so far, I don't think that we do have an actual challenge in implementing the action plan recommended.
Okay, well that's great to hear. And I wonder if any other members of the nutrition working group that are on the line have any perspective on implementing the joint action plan and ensuring that that's successful. Rutaina,
yes, I have an idea about it, and the perspective already I discussed internally in the office. And will be discussed, in the next meeting of the nutrition working group about how to implement the action plan through integrating some of the activities within the existing programs in other areas. For example, if we take the protection issues or the protection programs, we have the social protection and social policy programs. We have community programs outside the camps. As you know that, although we are targeting 640,000 plus refugees who are registered through UNHCR, but we have much more in the host community who are not registered. And going back to the history of the refugees who came from Syria, breastfeeding was a challenge even in Syria in the normal context before, and also in Jordan. And if we mix together, if we are talking about how to implement the action plan, we are taking into considerations the data before and after and now, including also the vulnerability assessment that was done or completed by the second half of last year, We are talking about vulnerability now rather than refugees, because we are towards resilience. So this is one, I'm not going to say that it's a big challenge, but it's a challenge on how to integrate those. We started already talking to our programs, how to integrate part of the action plan in the programs to raise the awareness of the people or the clients who are coming in to attend those let's say programs, especially with social policy, because there is part of it is to provide in-kind assistance and financial assistance to some families, but we are distributing now this financial assistance based on the vulnerability among Syrians, you know, who needs more, and based on the number of the children, and specifically the children under 5 in the family. So our part here is let's say to raise the awareness and to ensure that early initiation is being done, the timely introduction of complementary feeding and the type of feeding itself. As Ruba mentioned, because of the poverty and also the high cost of food in Jordan, mainly people are relying on high carbohydrate diet, which again, you know, affecting other micronutrient issues. We have a problem of micronutrient deficiency, mainly anemia and vitamin A deficiency in the country. That's what we are trying to help to reduce through the implementation of the action plan. So the first point is integration within the existing programs in other areas. The second point is the Ministry of Health. As I mentioned, because we have inside and outside the camp, and as mentioned by my colleagues Brooke and Ruba, whatever is being implemented inside the camps or in the refugee context, even outside the camp, any guideline or guidance note or program needs to be approved by Ministry of Health. I look at it from an opportunity point that, you know, it's opportunity for them also to integrate this within the normal or the regular program, and an opportunity to support the refugees in the country and the most vulnerable people. So this is how we are looking at it to introduce the action plan. The first point, as Ruba mentioned, we will go and attend, you know, all the other support groups and working groups, protection, WASH, and because we have also hygiene promotion issue in this, and we will advocate through the working groups and through the government and through the refugees themselves, through the community-based programs inside and outside the camp. The main point here, or it might be a challenge, is how to monitor the impact. You know, whether, you know, it's efficient or not, how to prove this efficiency if it is efficient, and how to correct if there is the measures, if there is any measure that needs to be, let's say, corrected or changed or tailored according to the context that we are not aware about. Because, you know, even the vulnerability is different from the north to the middle to the south, inside and outside the camp.
Thank you, Butena.
Okay.
Thank you very much, Butena, for that contribution. We have had a question in, but we also only have 1 minute left. So I'm going to just pose the question, and maybe this is something that the Nutrition Working Group can discuss, particularly as Butena mentioned some aspects related to this. It comes from Sona, and it says, do you have or see the need for behavior change communication strategy, given the challenges just described? So as I said, we don't have the time to talk about it now, unless Butena have a...
Yes, no, I just, you know, I will say yes, it's highly needed, and I already have put it, you know, on the work plan for this year, because as you know that we have now, you know, we'll be distributing very soon, maybe in 2 months' time, and we will invite you to attend also the dissemination of the results of the nutrition survey. It's a big survey, yes, in Jordan, and we are, you know, we studied actually the situation of all, you know, including the wealth quintile, the poor quintile, refugees, non-refugees, Syrians, Jordanians, and other nationalities in the country. It's being done, you know, through UNICEF in cooperation with WFP and UNHCR. So, and one of the main recommendations is to have a behavioral change, you know, strategy or yes, and action plan. It's not only a strategy and how to implement it according to the context of each group of the people or the groups we are targeting. Yes, definitely, yes, it's highly needed.
Thanks, Butena. All right, everybody, if you wouldn't mind just giving me 1 more minute before you all knock off, just to say a few things. So firstly, thank you very much to Brooke and to Ruba for your efforts in putting together this webinar, and also to all the participants. Thank you for coming and thank you for the questions posed. As I mentioned at the beginning, we do have an evaluation that we would really appreciate if you could fill out. It will take you approximately 6 minutes, no more than 10 minutes. I have pasted the link again in the chat box. This is a really valuable process for us. And to thank you and to show our gratitude for filling that out, I will send later on an email with the presentation slides and the recording for the webinar if you would want to recap or have any colleagues who were unable to make it today. I'll send the link to our website where the recording and the presentation slides and also lots of the resources that were developed during the deployment will be available. And on top of that, the aforementioned article that Brooke mentioned by Shura, I will also share the link to that. And there was also a request from somebody, I apologize, I cannot see who it was. Ah, yes, from Abdullah, to share the translated BFHI poster. So I cannot do that, but I have no doubt.
I can send it. No, I can send it to you, Ben.
You can send it to me. Okay, brilliant.
Yes, I can.
Right, well, I'll post that on our website as well, so that'll be available for you. So finally, to close, I would just like to say good luck to the Nutrition Working Group with the implementation of the Joint Action Plan. And I look forward to hearing about the successful implementation of that in the future. And finally, I have put up the slides for my contact details for the Tech RRT. If you have any questions related to anything related to the Tech RRT, and specifically any interest in potential deployment, potential technical advice, then please do get in touch. So with that, I wish you all a good morning, good afternoon, and good night.
خلصنا.